Hi everyone. Okay, so we are going to have a presentation over kidney test function. Now, keep in mind you're supposed to read your chapters and look through all that and look through your notes and all that. This is a kind of like quick synopsis and like a highlight reel of the main takeaways from your kidney test and function. So, the first thing I want to talk about is let's say that we had a cat show up to the hospital that was blocked. Okay, you bring it to the back, you assess your patient, you get vital signs, you notice that our heart rate is like, brrr, and so you're like, I'm gonna just put the ECG on this and see what's going on. So you put the ECG on, and you noticed that there's a delay and an abnormality within the T wave of the ECG. What if I told you that you also ran blood work and you noticed that the potassium, so if you ever saw blood work, there was a K, that's potassium, okay? And so what if I told you that the potassium was moderately elevated, like to an unhealthy level? Well, what can happen is potassium can send improper electrical impulses and charges to the cardiovascular musculature. And what that can do is it can freak out the T wave. Now remember, the T wave is responsible for repolarization of the ventricles. Okay, so it basically has an extended period of depolarization. Okay, so what do we got to do? Well, we got to unblock that cat. Number one, we got to get that potassium level down, because if it goes too long, it can be very fatal. Because we want to make sure that we have a proper ECG, because we know that the kidneys and the heart and the blood pressure and the kidneys are responsible for homeostasis, right? Everything works so that everything works properly. And hopefully we've got a good T wave going on. This one looks good. But for that cat, we've got to fix it. We've got to unblock, we've got to rehydrate, we've got to flush out those potassium. Because remember that the kidney is responsible for reabsorption and also eliminating things that the body does not need anymore. No, I'm not kidding you. It is true. So, let's review a couple of highlights for our kidneys. So, for our kidneys, they're going to play a crucial role in that, again, homeostasis. They're also going to make sure that they're going to conserve proper water and electrolytes and have fluid balance in the body. They're also going to make sure that we have a good pH level in our body. Now, anytime that you hear pH and you hear metabolic, think kidney. But then what's that other organ that also assists with our pH levels? Well, hopefully you're saying your lungs, because we eliminate CO2 in the exchange for oxygen. But we got to get that CO2 out of our body, because that is a waste byproduct. We got to get it out. Now, our kidneys are going to help regulate hydrogen ion concentration to help with the pH levels in our bloodstream. Again, they're going to be responsible for metabolic waste products, such as like nitrogen. And they're also going to help in the production of important enzymes and hormones. Like, for example, we have renin, R-E-N-I-N. That's going to play a key role in controlling blood pressure. And then, as you know, we have erythropoietin, which is crucial, that hormone, that is crucial for red blood cell production. So it's common for us to see patients with kidney disease being slightly anemic because of the erythropoietin. And they're also going to help synthesize prostaglandins, which are going to be those fatty acids that are involved in stimulating smooth muscle contraction and some other physiological things. So they're really good. We've got to have them. They're also going to be a key factor in lowering blood pressure and regulating acid secretion in the stomach. They maintain body temperature, facilitate platelet aggregation, support inflammatory control. They're going to activate some vitamin D. Really, they're doing a lot. And we've got to take care of our kidneys, because we know that systemically they play a large role. Now, do we remember this guy? The nephron. Let's quickly review. So, this is going to be the blood flow through the renal arteries into the kidneys. Blood flows from the renal artery into the afferent arteriole, leading to the glomerulus, and then into the Bowman's capsule, which is kind of like that yarn ball. From the Bowman's space, the filtrate moves into the proximal convoluted tubule, continues through the loop of Henle, into the distal convoluted tubule, and finally out the collecting ducts, and we urinate it out. Now, it's important to remember that the kidneys play a crucial role in reabsorption. And the nephron is going to have specific reabsorption capabilities. And basically, the substances that the body needs or doesn't need anymore, it regulates that. So, for example, glucose. Glucose, as we've known, we've talked about, is reabsorbed in the proximal convoluted tubule 100%. If glucose is found in the urine, that would not be 100%, or if it exceeds the nephron's ability to reabsorb it, this could mean that the patient that we're dealing with might have an underlying issue, such as diabetes mellitus. So then blood's going to return to the kidneys to the rest of the body via the renal veins, which will then collect to the caudal vena cava, and so on and so forth. So again, if we see glucose in the urine, that's bad. We need to do further diagnostics. We need to get full blood work, do the whole thing, because we need to figure out what's going on with our patient. Now keep in mind that both urine and blood are analyzed to evaluate overall kidney function. Can't just look at blood, can't just look at urine. All right, so when we look at blood, what are we looking at? Well, we've got two primary chemistry tests for kidney function. We've got one, which is BUN, not BUN, BUN. This is going to be blood, urea, nitrogen. So what is urea? Well, urea is the end product of amino acid metabolism. Well, what are amino acids? They're the building blocks of proteins. What are proteins? It's you, it's your DNA. By evaluating BUN levels, we can assess the kidney's ability to remove nitrogenous waste, which is urea, from the blood, and in a happy, healthy animal, urea is effectively excreted. However, if kidney function is impaired, urea is not adequately removed, resulting in elevated BUN levels. Now keep in mind, urea must be excreted in high volumes of water. So if a patient is dehydrated, we would have increased urea retention occurring, which would lead to higher BUN levels. Additionally, we can have some other factors that could be going on with our patient that can cause an elevation in BUN, such as maybe they're on a super high protein diet, or maybe they are going through high strenuous exercise, because both of those things can cause a decrease in the glomerular filtration rate. So all that to say, basically amino acids get broken down from those proteins. So if we're eating more, where the amino acids are being broken down more so in our gut, and then a strenuous exercise, we're overdoing it. Now, the next thing that we'll look at is going to be our chemistry for the creatinine. Creatinine is a form of creatine, which is found in skeletal muscles and is also a byproduct of muscle metabolism. Creatinine levels will correlate with muscle mass and overall the kidney function. In a happy, healthy animal, the creatinine is filtered through the glomeruli, and then we urinate it out. However, if a disease process is affecting the glomerular filtration rate, creatinine levels are going to be altered. Now, it's important for us to know and to understand that 75% of the kidney tissue has to be altered in some sort of way, and maybe non-functional or damaged, for creatinine to show any increase in levels. Therefore, it's really important for us to run BUN, creatinine, and a urinalysis, and then just a full workup in general, to be able to properly assess our patient. Now, there's an additional small test that we can do too. It's called a urine protein creatinine ratio, or a UPC. And the UPC, yeah, you know me, is a simple test that's going to measure how much protein is being lost through the kidneys. So it determines if the loss poses a health risk, because sometimes we have it, but if we have too much, that's not good. The test involves measuring the amount of protein and creatinine in a urine sample, and then it does some fancy math inside the machine to make it work and to give us that overall value. So IDEXX, for example, has clips for us to be able to run this and in-house rather than sending it out so that we can get fast results. Next, I want to talk about SDMA. Now, SDMA is an amino acid that's produced when proteins are broken down. Man, we're breaking down a lot of proteins. Okay. And excreted by the kidneys. It serves as an excellent indicator for kidney function. It's allowing us to detect kidney disease earlier than just BUN and creatinine tests alone. So it is an early biomarker for kidney disease. It tests to see if our patient could potentially develop kidney disease over time. Your textbook doesn't really dive in depth in this, so I'd like for us to maybe watch a quick video on what this is. So I'm going to do a screen share real quick. Let's take a look. Please hold.
Hello, my name is Sylvia Conway and I'm a UK veterinary surgeon. I'm pleased to be able to provide you with some information on an exciting new kidney test from IDEXX called SDMA. It is now available for the UK veterinary community. SDMA is a new kidney function test that detects kidney disease earlier than any other routinely available blood test. IDEXX reference laboratories will begin adding SDMA to routine chemistry panels in 2016, creating a new standard for chemistry panels. SDMA will be run alongside creatinine to help you diagnose kidney disease earlier and with more confidence. As you know, creatinine does not detect a problem until the cat or dog has lost up to 75% of their kidney function. With the new SDMA test, kidney function can be detected much earlier, on average at only 40% loss of kidney function. So what is SDMA? SDMA is short for symmetrical dimethylarginine. It's a methylated form of the amino acid arginine, which is released into the circulation during protein degradation. It is excreted almost exclusively by the kidneys. What's special about SDMA? Well, there are 3 key attributes. Number 1, because it is freely filtered by the kidneys, SDMA provides a good estimate of the glomerular filtration rate, or GFR. Number 2, as mentioned, SDMA increases earlier than creatinine in chronic kidney disease. A recent study in cats showed that SDMA detected chronic kidney disease on average 17 months earlier than creatinine. A similar study in dogs found that SDMA detected chronic kidney disease on average 9 months earlier. Number 3, SDMA is specific for kidney function. It is not impacted by lean body mass like creatinine is. Therefore, it more accurately reflects the true kidney function in underweight animals, including the geriatric skinny cat or dog, or the cachectic patient. At IDEXX, we're excited to provide customers with information on this revolutionary new test that will alter the standard of care you provide your patients. I hope this has helped provide a better understanding of the new SDMA test from IDEXX. If you would like to learn more about SDMA, please visit our website.
Why, thank you. Thanks, IDEXX. That was really helpful. And good to know. So let's think about maybe like a case real quick. So here we have Jimmy. Jimmy was brought in for his annual wellness exam and vaccines. Okay. When he's 13. Oh, wait. Let me back up. We need to do this segment. Jimmy, 13-year-old, domestic short hair, male neuter, domestic short hair. Great. We're 13. We definitely want to recommend some blood work and just some routine, maybe a senior panel, because after 7 years of age, they're considered a senior citizen, but don't tell him. Okay, his history. He was an indoor-outdoor cat. Was. Okay, so now not. I don't know. Further questions need to be asked. His owner reported that Jimmy seemed to be doing fine and there were no current concerns. That's great. Any coughing, sneezing, vomiting, diarrhea? Guess not. Jimmy is bright and alert and responsive. Normal temperature, normal pulse, normal respiration. Great. Good muscle mass. Awesome. Great body condition score. That's good. And then physical exam was unremarkable, except for some moderate periodontal disease. Okay, so we've got some dental disease. Shocker, 13-year-old cat, to be expected. So overall, a dental clean was recommended. So if we're going to do a dental cleaning, especially on a 13-year-old cat, but really any, we want to run some blood work. We want to run some pre-anesthetic blood work. We want to do a CBC to check our red blood cells, white blood cells, and platelets. And then we also want to do a chemistry panel to make sure that our kidney, liver, pancreas, glucose, electrolytes, those are all in balance. We also want to do an SDMA. So that's that early biomarker to make sure that, see if we've got early stages of kidney disease. Now, from the video, it said, hey, with 40% of damage or interference on the plate of the kidneys, we can detect if there's any issues or possible kidney disease to be developed. With creatinine alone, it was only there needed to be 75% damage to the kidneys. So SDMA, all the way. T4, we want to make sure that our thyroid, so T4 tests, we'll get into more of hormone testing in a little bit, but we want to test our thyroid to make sure our thyroid hormone is calculating properly. And then we also want to do a complete urinalysis. So we want to do that full workup. Now, luckily, so we can send this off. Okay, when I say send this off, we can send it out to the laboratory rather than doing it in-house. Some hospitals, you're able to do things in-house, but it's usually way more expensive. So the best bang for the buck for the client is to send that blood work out. So let's take a look at this blood work. All right, we can see here on Jimmy, our glucose is pretty okay. Sometimes with cats, especially when they come into the hospital or to the vet hospital, the office, we can see what's called a stress glucogram. Now that would mean that we would have an increased glucose value and reading, but it would be due to stress. This is in cats. Now, is coming to the vet hospital stressful? Yeah, it definitely can be, but we want to try to make it as least stressful as possible because we don't want something like a stress glucogram. Now, this reference range, this would be more like if we were like 175 or 200, maybe 220. But if we get to the 300 to 400 range, that's not a stress glucogram. We got something else going on. We need to dive a little bit further, but I digress. Ooh, we were in the SDMA. That looks like that's a little bit elevated. Our creatinine's okay, BUN's okay. Phosphorus, what's that? You ask, I'm going to tell you. Phosphorus levels are something that we are going to test to evaluate kidney function as well, because the kidneys play a role in regulating the phosphorus balance in the body. Phosphorus is filtered out of the blood by the kidneys, and then they're functioning normal and they're going to excrete the phosphorus in the urine. So when kidneys are damaged or they're not functioning properly, such as a patient with like chronic kidney disease, they're going to lose the ability to filter out phosphorus efficiently. And that can overall lead to elevated phosphorus levels in the blood, which is noted as like hyperphosphatemia. And that's going to be a sign of reduced kidney function. Now note that phosphorus and calcium have a balance and relationship too. They're closely related in metabolism. And if there's an imbalance, we can have serious consequences, especially like with kidney disease. High phosphorus levels can cause calcium to leak from the bones, leading to weakened bones and contributing to also what's called renal secondary hyperparathyroidism. Remember, the parathyroid is going to be in charge of regulating those calcium levels. So yeah, it's all connected. And overall, like if we had a patient that has elevated phosphorus levels, we want to look at controlling those and managing those as best possible. Well, what's one way for us to do that? Well, it's through food. So diets for pets with kidney disease are often low in phosphorus to reduce the strain on the kidneys and prevent any sort of complications. So if the phosphorus levels are too high, the phosphorus binders may also be prescribed to reduce absorption of the diet too. And that's another medication that we can kind of look at. So phosphorus, we got to make sure that we're taking a look at that. Anyways, now you know, back to Jimmy. So looks like our potassium, chloride, sodium, those are all good. Those electrolytes are good. Our total protein, our albumin, which help us kind of figure out our liver, that looks pretty good. We ran a thyroid hormone looks like it's doing good. So, okay, what are some next steps here? Looks like this doctor was like, hey, overall everything looks okay, but our SDMA, and I probably explained to them what SDMA was and why we run that. And it looks like we also considered having them recheck in 2 weeks to make sure that we're drinking water. Maybe we're on a diet for senior patients. We're going to include doing an ultrasound on the kidneys, and we also want to check our blood pressure. We want to do a urine protein creatinine ratio, and we want to do a urine culture and sensitivity. So it looks like the follow-up and diagnosis. So Jimmy came in a month later, and we did some blood work, and it looks like the SDMA remained increased but stable. We were at 23, now we're at 19, and the specific gravity was unchanged at 10/15, and the remainder of his blood work looked to be pretty normal. The abdominal ultrasound showed no evidence of urinary stones or infection. However, he had some small kidneys, which looks like the doctor said could be consistent with chronic kidney disease. Then we did a blood pressure, and it looks like it was 175 millimeters mercury, which is persistently increased when Jimmy was rechecked a few days later. So what does this mean? Well, we know that our blood pressure and our kidneys have a correlation here. And we also know from our diseases too that there's a thing called systemic hypertension being high blood pressure. We want to make sure that we do not have any blood pressure issues chronically or consistently, because that could cause further issues. But we also know from systemic hypertension that it can cause acute blindness and potentially lead to retinal detachment or degeneration, which would be bad. So, with the results in hand, the doctor followed what's called the International Renal Interest Society, CKD, which is chronic kidney disease staging guidelines. Basically, there are these, if you do the SDMA, there's then an algorithm, which we'll talk about in lab. We'll do another case study, and we'll use the algorithm, and we'll use the IRIS. And it basically is a guideline to go through and kind of show the doctor, hey, if you get these results, now do this. If your reference range was above 20, do this. If it was below 20, do that. And it's just further diagnostic and further testing. And then it also is going to stage, so like Jimmy got a stage 2 of the disease, it will stage these diseases. Which sounds kind of like, what? And maybe complex. But it's great because if you think about it, kidney disease is extremely common, especially in our cats. That's why we have so many food options. Did you also know that the first prescription veterinary diet was KD for Hills? Yeah, kidney. I'm not kidding you. And so it's really important and crucial that we have all this knowledge and we have all this research and we have this information and these tools to help us better take care of our patients. And so it looks like he did get placed on some high blood pressure medication, maybe amlodipine or something like that. Or maybe I said that wrong. Anyways. And then his owners are going to switch him to a kidney therapeutic diet. We want low phosphorus levels for that too. So, yeah, that'll be good. All right. And so now let's kind of switch gears and let's talk about running a urinalysis and what happens if we see maybe this guys. So let's talk about just uric acid in general. And these are uric acid crystals. So you may recall that Dalmatians are going to commonly have uric acid crystals in the urine. And this is because Dalmatians excrete uric acid rather than allotonin, which the uric acid is a metabolic byproduct of nitrogen catabolism. So primarily, this is going to be produced in the liver. So in most animals, uric acid is transported to the kidneys while bound to albumin, which is that plasma protein, and it passes through the glomerulus and it's being reabsorbed by the renal tubules. However, in our Dalmatians, this reabsorption does not occur in the same manner. Therefore, we can actually see this. Another thing that we could say about our uric acid is our avian species. Uric acid is the end product of nitrogen metabolism, and testing for uric acid levels provides a valuable indicator of renal function, especially in birds. In cases of renal disease, uric acid concentrations increase, like more than 70% of kidney function is lost, and that's going to make it a key marker for diagnosing any sort of kidney issues, especially in our avians. All right, so now that we kind of hit a lot of those highlights, and that was a quick highlight, so make sure that you go back and you check your actual highlighted information. Let's do another case study. Let's crack the case. In order to do this one, we're going to pull up a case study from IDEXX. Let me do another screen share. Please hold. All right, we have Muriel. Muriel is a 9-year-old female cat that's presenting complaints with mild PUPD, intermittent vomiting. Sometimes it's containing hairballs. I don't blame you. Oh, look, she's a smush face. How cute. Sorry, brachycephalic. She does have an unkept coat and a dirty tail on physical exams. And it also looks like we maybe are having some weight loss. We've got some signs of diarrhea, tachycardia, dry mucous membranes, decreased skin turgor. We're dehydrated. And a palpable thyroid nodule. Wow, we've got a lot of information just in this right here telling us maybe we got some things going on. So let's read through this together. We have moderately, let's look at our hematology first. Sorry, I'm getting ahead of myself. So down here to the hematology. Looks like our red blood cell count is kind of in the middle. However, it's like at a 10 and the range goes up to a 12. Our hematocrit's okay. Our hemoglobin's high. Our white blood cells are high, being our neutrophils and our lymphocytes. Now, remember, what's the order in which are the most common of our our white blood cells? Neutrophils, lymphocytes, monocytes, eosinophils, basophils. They've got it listed there, which is really nice, but just make sure you know that in your brain too. So what did the doctor say about this? Looks like we have moderately elevated hemoglobin, and the red blood cell count's also at the upper limit of the reference range. Okay, you know the reference of hemoglobin and red blood cells, those are correlated. And looks like the hydration levels, a hypothesis of dehydration is considered, absolutely, which we got that from the skin turgor and dry mucous membranes, and yeah. We could also say that hyperthyroidism could also explain this phenomenon. Remember that hyperthyroidism is more common in cats. Hypo, low thyroid hormone, is more common in dogs, but it can happen the other way. But we did notice palpable thyroid gland on palpation. So what should we do with that just by reading that? Well, we should probably test a T4, which is a thyroid hormone. So we also note the presence of neutrophilic leukocytosis along with moderate leukocytosis with no alarming signs of immature unsegmented granulocytes. Now, what are immature unsegmented granulocytes? Those are going to be band cells. So this then goes in to explain what an adrenaline rush that's associated with a state of fear and excitement could cause nonspecific elevations in our leukocytes, which are our white blood cells. So I talked about how our patient can have a stress glucogram. Well, they can also have a stress leukogram. And when I say patients, I mean cats. Okay, so is that a stress leukogram? Who knows? But remember, when we have elevated white blood cells, we got to think, are we having an inflammatory response, or is there maybe an infection going on? So we can't just say that it's a stress marker. So now let's just, before we read, let's take a look at our chemistry over here. Glucose, it's toward the higher side, but we're doing okay. The urea and or the BUN, the creatinine and the SDMA are all three elevated. Hey, that's not great. What does this, you just looking at this blood work, what does that tell you? Hopefully your mind goes, kidneys. Phosphorus is okay, which is cool. Calcium's okay. Total protein, albumin, globulin, ALT, alk-phos, GGT, T-bili, and cholesterol, which cholesterol, T-bilirubin, GGT, ALT, that is referred to our liver. So it looks like our liver's okay. And then we have sodium, potassium, and chloride. That looks okay. But then our T4 was high and our UPC ratio was high. So just by glancing at this blood work, my brain goes, kidney. So let's see what the doctor said. So the biochemistry assessment rules out diabetes because our glucose is okay. We've got normal blood glucose level. The liver enzymes are unremarkable. Again, those liver enzymes are going to be albumin, total protein, globulin, ALT, ALKP, GGT, T-bili, and cholesterol. Given the history and our signs, chronic kidney failure is among the diagnostic hypothesis to explore. Now remember, we do a physical exam, we run some blood work, and we get a DDX, which is a differential diagnosis. So we think of all the possible issues that could be taking place, and then we try to narrow them down. So it's not the overall like pinpoint, because sometimes we don't have the clear, concise thing. So the hypothesizing is kind of like the differential diagnosis. Overall, the biological assessment does not indeed reveal kidney failure, but we do have an elevated IDEX SDMA, we have an elevated BUN, we have an elevated creatinine, and it looks like our electrolytes are okay. The urea creatinine ratio, that UPC, does not support exclusive pre-renal kidney injury, and the elevated SDMA does indicate a decreased glomerular filtration rate. So overall, we did a urinalysis and UPC. They're performed to complete the kidney function testing. Remember, kidney function test, we want to get this chemistry, but we also want to look at a UA. We also want to do that UPC. We then see that there's strong clinical suspicion of hyperthyroidism. Why? Because we did a T4 test and it's high. Hello. So let's do that UA. We did the UA, and here are our results. What's our specific gravity? 1045? Okay. Okay. We didn't see any crystals or any white blood cells. Okay. pH 6.5. Protein 2. Okay. All right. Well, the urine specific gravity is mildly increased and is compatible with clinical identification of dehydration, which we see that. You know, our specific gravity is going to increase with dehydration because it's more concentrated, and it will decrease with overhydration. The urine protein creatinine ratio is moderately elevated, especially in light of an inactive urine sediment. But in that sediment, there was no blood or inflammatory cells. So it was pretty clear. We could look through all those things. And, okay, big thing here. A complete urinalysis is performed before any rehydration. Why would we do that? Well, that is essential because we know that the solution to pollution is dilution, right? So we do not want to dilute out any of our possible substances, because we want to make sure that what we're reading is exactly what the animal is here for and have an issue with. So we don't want to dilute anything. So with the refractometer, we were able to hypothesize some kidney failure as well because of the higher density. The dipstick looks like it showed interpreted even in the light and all that. There was a level 2 shown, and it needs to be confirmed. We look at that. So if we saw the 2 on the protein urinalysis, we then are going to do a UPC, right? Because it's urine protein creatinine ratio. So what did that find? Well, first of all, the urine culture, there were no bacteria or cell elements found. So kind of rules out inflammatory of the lower urinary tract. And so the UPC. So we repeated the UPC measurement, and we could confirm the persistence of proteinuria. And the UPC is going to provide prognostic information because UPC mortality are directly linked. So the higher the UPC ratio, the worse the prognosis. So for Muriel, her prognosis is actually uncertain because of how that fell. Now again, this brings up the IRIS table and staging, which we'll do more of together. It's just easier to follow when we can look at it together and all that. But it's like, oh, where do we go from here? Well, I'm not too sure. Looks like we did a blood pressure, systolic blood pressure. Remember, systolic is when things are contracting. Diastolic are when they're dilating. So this was when it was like heat contracting. It's at 180 millimeters of mercury, and it looks like we tested it again, and it was confirmation of hypertension, which we know, like I've already said, that blood pressure and kidneys do correlate. So we took some x-rays. We're doing the full workup here. Cardiomegaly is noted and characterized by bilateral enlargement, producing characteristic of the image. St. Valentine heart. Okay, whatever. And yeah, so overall, we're diagnosing Muriel is hyperthyroidism associated with chronic renal failure. Okay, so what do we do for Muriel? Well, hyperthyroidism can increase cardiac output. Therefore, it's going to reduce peripheral vascular resistance. So, increase blood flow in the renal artery and increase in glomerular filtration rate. All of these mechanisms can not only lead to apparent decline of blood urea creatinine, but also to glomerular hypertension and hyperfiltration. So this can potentially cause or aggravate incurrent kidney failure. So ultimately, all of what's going on with her is not helping nothing. We gotta get a handle on this. So her systemic hypertension and secondary renal failure may be associated with hyperparathyroidism. So what do? We're going to monitor that SDMA and that creatinine as well as the UPC. And overall, if we can monitor those things and figure those out, then that can kind of lead us to what is the main cause of this. Okay. Once the hyperthyroid treatment is initiated, the UPC may normalize to continue to increase if the chronic kidney failure is then progressed. So once we start the hyperthyroid medication, the UPC can normalize or it can increase. So that's why we've got to figure out what's going on with Muriel, like which one we're trying to work with first. So we have to monitor her very closely. It's not just here's some medicine, here's some food, here you go. We've got to look at all of those factors. So let me stop the screen share real quick. So first of all, let me just say, great job. I'm proud of you. This was a very quick, I think it's like 40 minutes, very quick, just kind of highlight reel of our kidney test function. Make sure that you go through the highlighted sections as well, because there's also talk about clearance testing, water deprivation testing, all of these things. A lot of those tests that your book goes into detail is not something that you're so much going to be doing in practice. But your VTE does ask about it. And you never know. You may work in a diagnostic lab one day and do these tests, which would be so cool. So make sure that you familiarize yourself with those and then answer those review questions on those. We'll do more of kidney blood works and kidney case studies together in class when we meet, but this will just be kind of like a quick introduction to keep familiarizing yourself with looking at blood work. This is where all the puzzle pieces come together, and it's a lot of fun. So I hope that you enjoyed this, and I hope you have a great day. Let me find the button.